Now let's take a little bit more focused look at physician needs for value-based care success. Mark Twain is said to have said, "I am in favor of progress. It's change I don't like." This quote appeared in one of the articles cited for this lecture. It seems very apropos when discussing physician needs for value-based care success, or for that matter, any change they might be facing. Physicians are knowledge workers who are typically characterized and trained to be individuals who are independent thinkers and for whom learning is creative, inquiry-driven, and self-controlled. Their decision-making is autonomous, where traditional command and control paradigms are not effective for them to contribute to achievement of organizational interests. In some cases, physicians' reaction to change can seem schizophrenic. In surveys for what they need for value-based care, they regularly cite clinical protocols to inform decisions, care pattern data for performance measurement and improvement, care pattern data for outside referrals, and EHR technology that is usable and will support their decision making. Yet they express many issues associated with collecting and reporting burdens imposed by quality measurement, measures that do not accurately capture quality of care, resources, particularly IT, for quality measure collection and reporting are burdensome. The trustworthiness of the data used in quality measurement is questioned, and the need for a patient severity factor to be included in measures to account for variation is strongly desired among physicians. What is also interesting is that while physicians collectively seem to malign clinical protocols and quality measurement, those physicians who have access to automated clinical protocols are more in favor of controlling costs and quality in healthcare, measuring performance, reducing clinical variation, value-based payment, and public reporting of outcomes. In keeping with the nature of physicians as knowledge workers and reflecting Mark Twain's quote, it appears that as the old saying, "I'm from Missouri, prove it to me," applies to physicians from around the world. Unfortunately, their proclivity for being independent thinkers and autonomous in their decision making precludes even their colleagues who have had success in value-based care to be successful advocates for their peers. As such, demonstrating results and providing evidence they can trust on how the results occurred is a much needed step in the direction of physicians achieving success in value-based care. Certainly their expression of needs reflects the fact that they want to do the right thing, and I believe that with a sufficient body of knowledge for them to gain trust, this will help them overcome fear of failure, fear of blame, public humiliation, etc., that causes them to sometimes be skeptical, to find ways to shift blame, or to rationalize differences outside of their own actions. So the American Medical Association has developed several tools to help physicians prepare for value-based care. Their Steps Forward program provides 5 steps. The first one they recommend physicians do is to identify patient population and opportunity. This refers to stratifying each physician's patient population according to level of risk for things like hospitalization, high use of emergency departments, multiple chronic and complex conditions with multiple comorbidities, age, and potentially other factors, such as whether a patient lives alone or with a spouse, where they live, their education level, their health insurance status, and how their type and volume of services may change as time goes on. We'll look more closely at risk stratification in another unit, but the purpose behind the process is to identify which patients are or are likely to start driving high cost and therefore need specific targeting for additional attention. The second step the AMA recommends is to design a care model. And this refers to addressing the targeted population or populations, group versus individual physician, identifying what services are needed for these populations, the workflows required to provide care to the populations, staff needed to support such a new model of care, roles and responsibilities of each member of the care team, including both physicians and support staff, frequency of patient contact and modality of contact, phone call, email, texting, portal messaging, and frequency of visits. For each population, measurable success metrics should be identified and baseline data collected to quantify future impact. The AMA suggests this be automated via an electronic health record and or a population health registry. The care model also should include an understanding of transition costs and revenues. Costs will likely accrue primarily in changes in staff roles and potentially additional staff. And these staff could be shared across multiple providers, such as within an accountable care organization or clinically integrated network. Staff requirements include patient outreach coordinators, nurse educators or navigators, care coordinators, super medical assistants, which are those who can and are allowed to work to their level of certification, referral coordinators, transition care nurses, and extensivists, which are primary care providers who provide comprehensive and coordinated care to patients with multiple complex medical issues, and hospitalists. Practices are also extending physician capabilities through nurse practitioners and others for care transitioning and patient engagement. The third step is Partner for Success. This encourages the use of resources across settings in which the patient population experiences care. We've just suggested the need to share staff, for example, within an ACO or clinically integrated network. The fourth step is drive appropriate utilization. In the new care model, this refers to reducing unnecessary costs or variations and producing high-quality results to drive patients to the practice, thereby improving revenues, or at least assuring a consistent stream of revenue in a risk-based environment. Quantify impact and continuously improve is the final step. It's certainly the feedback mechanism in this new system of care. Not only should this enable a practice to look at internal opportunities for improvement, but to reevaluate and make adjustments in the care model and help with negotiating new and different contracts with health plans, partners, and employers as the new model becomes successful. Now let's shift our attention to care delivery needs for value-based care. Beyond organizational and physician needs for value-based care, there are needs that can best be characterized as care delivery needs. These focus specifically on the patient member, customer, consumer, whatever you might want to call that, of healthcare services, payment for care, coordination of care, and health services. Care delivery changes that are starting to be documented that need to take place include the following. First, convenient and timely access to care for patients. This is one of the tenets of patient-centered medical homes. The patient should be able to get the appropriate level of care, not just in the emergency department, but at times when they are best able to seek the care, such as evenings and weekends. Second, coordinated and seamless care and payment for care have been described as critical in value-based care, and it is starting to occur. However, it needs to be much more seamless and easier for patients to navigate. Similarly, payment for care from the patient's perspective is currently a nightmare. Improved registration processes, financial counseling, employee accountability to ensure bills are accurate and easy to read, and trending to turn complaints into opportunities for improvement are all needs that will improve the patient experience of care. Next, linguistic and cultural competencies should be obvious. These are needed to improve communications with patients, including using alternative communication modalities such as social media as appropriate. Primary care and behavioral health integration is a critical need, as it is coming to be recognized that depression and other mental illness have a direct impact on medical conditions, and critical shortage of behavioral health specialists mean much more primary care and behavioral health integration is needed. Patient-centered care refers not only to patient-centered medical home, but to the focus on me as a person and not as the hip in room 202. Patient engagement at all levels is required to ensure treatment regimens, health and wellness recommendations, and basic health literacies are competencies that are understood and adopted by all stakeholders at their level of ability, including patients. Governance of health system entities, providers, health plans, governing entities, and others need to include patients to represent their interests, perspectives, and concerns. Patient rights and responsibilities, in addition to patient engagement, need to be clear and upheld by all stakeholders. Continuity of care around physical, emotional, and social needs supports the whole person focus that treating the person is the best form of treatment for an illness or injury. Self-management of medical care is more than patient engagement. It is the ability to utilize applicable medical modalities after appropriate training and as supported by the medical community. Health, wellness, and prevention have been a mantra of employers for some time, but not so much for providers. These services will surely reduce risk in value-based care. Shared decision-making and shared accountability not only are needed in value-based care, but are two sides of the same coin. Providers need to take the time to help patients become part of the decision-making for their care, but patients must also be held accountable for carrying out their part of this process. And lastly, personal health records are not only a way to achieve better interoperability and patient-reported outcomes, but a means to support patients in their consumer actions. Ethical decision-making, ensuring the values in value-based payment. We discussed this in Unit 2. As this lecture looks more deeply at the operational needs for value-based care, it seems appropriate to remind ourselves of the importance of ensuring that making things right does not also produce wrong. A paper published in the Journal of the Catholic Health Association of the United States by the Senior Vice President, Community Health and Values Integration at Centura Health outlines several areas where much good can arise from the changes on which we are embarking, while also highlighting potential ethical dilemmas. The article observes value-based care, they call value-based payment, has the potential for more collaboration, less wasteful care, and more of a preventive ethos. But it warns that as alternative payment models encourage higher quality and lower cost and offer providers greater responsibility for the factors driving healthcare costs, the moral distress of health professionals will continue to rise. The ethical complexities in value-based care inherently present challenges. Specifically singled out are price variation, transparency, and physician incentives, particularly surrounding elective surgeries and procedures, suggesting that these provide new territory for ethicists and mission leaders. The article does not advocate for not adopting value-based care, as it observes that with every change ever comes a new area of ethical scrutiny. And while the article does reference mission leaders, it does not suggest that the ethical issues that always arise are unique to any one religion or significant change in the lives of any people. It does, however, make it clear that new ethical challenges require new skill sets to ensure that collective values are preserved as we make such a profound change. Indeed, I believe that ethical scrutiny is part of the set of needs for value-based care success. So given this to think about suggests to me that it is a good time to close this part of Unit 4. We will pick up our focus on operational needs for value-based care, specifically with looking more closely at quality measurement, best practices, workflow and process improvement, and continuous learning in the second lecture in this Unit 4. Please note that the references for this lecture and the second lecture in Unit 4 are compiled at the end of. For our references for this part of the lecture in Unit 4, please see the last slide in the second lecture of Unit 4, as there's overlap between the two.